3, 2, 1, boom. Heather Sowada is our guest on Conversations with Interesting People. You and I have been friends for 6 years or so.
7 or 8 years.
Has it been that long? I think I've only been in Iowa City for 7 years.
Maybe 7 years.
But sometime in there, and I really appreciate you being here. You are fascinating and have so much going on. So I want you to just kind of start out by telling us, before that, we just said I was going to do this. Before we get started, I do want to give a little disclaimer that Heather is a professor at Mount Mercy University, but today she is representing herself, and we want her to be completely free to talk about whatever she wants, but she is not officially representing Mount Mercy University. And she also told me just before we got started that she's not representing any other LMFT programs, and I'll let her tell you what that is. So all you people listening that are just looking to get on Twitter and be all nasty or whatever it is, leave Heather alone. She's just being herself today. So Heather, tell us a little bit about yourself and where you grew up and your educational background and what you do for a living.
Sure. So again, my name is Heather Morgan-Sowada. I hyphenated when I got married. And since that is quite a mouthful, all of my students call me Dr. Heather. And the little kids that I work with too in my therapy practice call me that. And it makes my heart just so happy whenever a little kid calls me that. I feel like I've made it in this world. So yes, the disclaimer of I'm not speaking for Mount Mercy University. I'd also, as a licensed marriage and family therapist or LMFT, I'm not speaking for any other marriage and family therapists, just my own opinions, and not for the field of marriage and family therapy as well.
Okay.
But yes, I'm a full-time assistant professor at Mount Mercy in their marriage and family therapy program. So I teach for their master's MFT program and their PhD in MFT, which we just got started last year. And I'm also the owner of Resolute Therapy in Hiawatha, actually. It's where the office is located, and just Cedar Rapids adjacent. And there I specialize in working with body dysmorphic disorder and gender dysphoria. So if people aren't familiar with what that is, essentially I'm very passionate about working with individuals within the trans or queer or gender nonconforming community, and to help them to recover from gender dysphoria in whatever way that might be for them. And then I also, with my passion for body dysmorphic disorder, that comes from my own struggle with body dysmorphia. So two completely different disorders, but things that I'm both equally passionate about working with. So
two different, but somewhere in the same genre in there, I guess I would say.
Yes.
And something that we're going to get into each one of those, and you can share as much about your own struggle as you want. We did a little bit of internet stalking before we got started. We read and so forth. One of the things I think it would be good to start out talking about, and you and I have talked about this, Heather's been nice enough to have me as a speaker at her class, several of her classes actually, is that there's a definition kind of overlap, I think, between what you do and what I do. And I think it's confusing to some people. So I'm a psychiatrist, and then there's people that call themselves therapists and counselors and psychologists. And there's a variety of degrees in there that people can kind of have that lead to one thing or another. So you mentioned LMFT. What are some of the different training programs? If somebody wanted to be a therapist or a counselor, first of all, is there a difference? And then what are some of the paths they might take to get there?
Sure. So there's lots in Iowa. What we typically have is 3 different degree designations. So there is LISW, which is a licensed independent social worker, or an LMHC, a licensed mental health counselor, or LMFTs, licensed marriage and family therapist. In other states, their licensure might be called different things as well. I think out in California, it might still be called a licensed marriage, family, and child counselor. Okay. So they just call them different things per different state sometimes. But those are the 3 designations here. There's several different, well, not several, I guess. I'm trying to think of how many different mental health programs there are. I know UNI has a mental health counselor program, and Iowa has a master's and I believe a PhD in social work as well. And Iowa also has clinical psychology and clinical counselor program, I believe, as well, for both master's and PhD. So I graduated from Iowa last May with my doctorate in psychological and quantitative foundations.
And that's a PhD?
Yes, PhD, okay. Yep. So, or psych and quant department is what we call it, with a specialty in couple and family therapy. So I can't speak to some other programs, but of course then we have the programs at Mount Mercy, which are phenomenal in my opinion, but I'm biased.
I just think, so thank you for that. And I think there's just a lot of people, I know I see them in my office and, I know somebody who's in psych. And, I think the term counselor especially, there are people who will go to, say, like a 2-year Bible college and they'll kind of hang out a shingle and say that they're a Christian counselor. And then you mentioned Master's of Social Work, but there's a Bachelor of Social Work. But in order to get a license, like you said, there's different levels. And I think one of the big differences is a psychiatrist is a medical doctor.
Right.
And so I can prescribe medicine.
Whereas I can't.
Right. And so there are some, now Iowa's been one of the states that, aren't there some levels of counselor that can now?
And not to my knowledge, without their medical degree. So some psychiatrists go on to also get a master's degree in their field with like mental health counseling or that type of thing, just to further their ability to do therapy, and then they do both. But not to my awareness.
I thought Iowa had something about if there was extra training, there were some kinds of therapists that could prescribe. Because I remember when I was working with Dr. Christensen, who and he and I had, our practices were in the same building, is the best way to say it, that the LMFTs were not going to be included. And I remember that being a bit of a source of irritation for Jacob, who at that time at least was involved at the program with Mount Mercy. This is me saying this and not Heather. But I never did hear what happened with that because I left the university, I finished my residency, I went to private practice, and it's not really on my radar that much. None of the therapists in our building, maybe it died. It was up before the Iowa legislature at one point. I don't know what happened.
Yeah, I think it was a bill that was up for the legislator to vote on, and I believe it died on the floor. So I can't speak to some of the specifics about that. I tend to live in my own little bubble of grading and therapy, but I do remember that there was something going on with that. I think to be honest, my big thing is because to my awareness, that would have required me to have like 2 more years of education and to do like a residency with within a hospital setting, that type of thing. And I'm thinking to myself, I don't want to do more school.
No more school.
No more school.
Well, and I think there's a beauty in the differences in kind of what we do. So rather than me just kind of say what I think, as you look at the profession as a whole and how people that are trained like you and like me work together, how do you see that dynamic? What are pros and cons that you kind of deal with every day?
Well, I think one of the big, you asked earlier about kind of what sets apart LMHCs and LASWs and LMFTs. Well, what really sets apart LMFTs is that we come from a systems perspective, right? So we fall in line with something called systems theory. That's our base approach to everything that we look at, or how we view the way that we do marriage and family therapy, which essentially is that problems happen between people, right? Not within the person. And at the same time, we know that the body itself is a system, right? But we don't have the education, the knowledge like medical doctors do to be able to know like what's going on within that system medically, right? Physically. And I mean, we take classes in like neuropathology and things like that. But I think that that's where the relationship between like people like me and you can be so helpful, because I might know that someone is struggling with, generalized anxiety disorder because they fit all the criteria in the DSM-5, but then I don't know always how that might respond in their body. Like, whereas working with a psychiatrist who has their background, who has their medical degree, is able to be like, okay, well, this is what's going on in their body and that type of thing, which I think is great.
So if they have a thyroid disorder as an example, that might look like depression or anxiety or ADHD, something like that. Exactly.
And I think that that's, part of systems theory is to remember that no one lives on an island. Problems don't just reside within that person, and there's so much going on that contribute to that problem including internal, not only psychological, but physical issues too.
I think one of the beauties that I see on a daily basis is that I get 30 minutes for a follow-up. I get 30 minutes no more than once a month unless something's really going on. Usually it's every couple months, whereas most people that are doing therapy get 50 minutes every week, every other week. There's a lot more time to develop the relationship, to sort of see people as they improve kind of over time. And then that can be really helpful. I think one of the things, and I mentioned this when I spoke to, I think it was your ethics class, is that then builds a lot of trust between you, the therapist, and the patient, that if then medical advice is given or something is being said without kind of us being on board, it can wind up being, can be tricky. I was going to say detrimental, which it can, but it can be good. But so, I mean, how do you deal with that when you're working with physicians or patients that are saying, hey, what do you think about this or that this other provider is doing?
Right. Well, when... like if they are, like I can speak to, like if clients ask me directly, like what do you think I should do about, my big thing is I always say, right, and like we reinforce that, like when you came and spoke for my ethics class, that you need to talk with your physician about this, you know, that oftentimes what I will explore with people is, okay, let's look at what was going on when you were off of that medication or beforehand, right? And let's look at the progress that you've made and what do you like maybe creating a game plan with them of if symptoms come back up again as a result of having the medication or going down, but always reinforcing for them, you know, talk to your doctor about this. Like, do not make a decision solely on your own. The thing that always like, it will forever be a therapist like thorn in our side is when people just go off their medication without talking to their psychiatrist. And it's like, why are you doing that?
It's a thorn in your side. It's a thorn.
I can only imagine.
It's a thorn in everybody's side. One of the things I think would be great, and I can't imagine how a system would work like this just because of time. But I think it would be interesting to have a team approach where we had, let's just say an hour and a half because of the time frame I just put out there. And someone like you and someone like me could be in the same room and we could hear the same thing at the same time and kind of come up with that plan together. I think that could be really neat.
Oh, I agree. I think it'd be wonderful. Well, again, thinking like more macro from that systems perspective, it doesn't make sense to not incorporate an entire treatment team for a person, right? And that doesn't have to be just the quote unquote professionals, right? Their treatment team could be their best friend who always goes with them to their doctor's appointments, or, you know, it can be a multitude of people, but keeping in mind like all those different perspectives are really helpful, and not just relying on my perspective or your perspective or this other person's perspective that's working with them, but have people actually collaborate.
Yeah, I think it's difficult too, because when we're even if you worked in the office next to mine and we were on the same health record and I could read your note, even if you wrote it beautifully, you don't get the flavor of it in the same way.
Right.
We all get really busy.
Time.
Yeah, and it's funny. It always reminds me of like the old karate movies I used to watch as a kid, in that, you know, I listened to somebody for 25 minutes and what I write is patient is doing well.
What does that mean?
I mean, that was right. So you obviously can read that and go, oh, Adam thought everything was fine. But what does that mean?
Right.
You know, maybe they said, I'm going to therapy every week and I think it's working well and the medicine's going great. But in order to try to, even if I did exactly dictate what they said, then the note would be long and cumbersome and time and it'd jump all over the place in some cases. It's interesting because I think the patients really think that we spend a lot of time coordinating, and much as we would love to, A, time, B, distance in terms of like, you could try to call my cell phone, but I'm in with somebody, we both have families.
Right. Yep. Yeah. I think time is the biggest hindrance to collaboration, because I think most people in this field, they want to do the absolutely very best for their client, and it can just be hard to get everybody on the same page, you know, as far as communication goes.
This may be a tough question, but I get asked this by patients all the time. It seems like there are a lot of kinds of therapy, and people will say to me, well, I want to go to somebody who, let me just sort of throw out, just like the military, we love our abbreviations, but people will say play therapy, CBT, DBT, EMDR is sort of a big one. And then you still get the old school people that think we're going to put them on a couch and face them away and ask them about your mother, which is called psychoanalysis. This is a big question. Can you kind of give us a breakdown of some of the different kinds of therapy, both what you do and some of the effectiveness that you've seen in, in different kinds of patients? That's a whole semester course I just asked you to do right now. But so define some of the therapies for us, I guess, is an easier way to say that.
Sure. So you just listed off quite a few. I think it really boils down to, like, I tell my students that, we teach the major systemic theories at Mount Mercy. So those would be, some of those are the more modernistic, like CBT, but CBT through a family systems lens, right? Or CBFT is what we call it. But then there's also... Can I get you to... Oh, sorry. Just a little closer to the mic, thanks. I don't know how to speak into a mic, people. I've never done this before.
You're doing very well.
This is weird for me.
Heather told us how nervous she was going to be. She's doing great. Keep going.
I just have to forget that we're actually like on camera, and then I'm fine. But so then there's the narrative therapy approach, the symbolic experiential approach, what I love to practice, which is solution focused brief therapy, or SFBT. And so really I can speak more to the family systems approaches than I can what other types of programs do. But one thing that really sets marriage and family therapists aside from LASWs and from LMHCs is that we do have that systems perspective, where oftentimes those other fields are more taught therapeutic models that are more driven at just doing individual therapy. Okay. Not that they're not taught those other models as well. I think our approach, like, there is rarely a time in our training where we didn't have a couple or family component. Like when I was a master's student and they made us do role plays, right? It was always within a couple or family dynamic, whether the family be, parent, child, both, all parents, however that family might look, and their children. So I'm used to having multiple people in the room, whereas sometimes mental health counselors or LASWs, again, this is blanket, like there might be many that do family or couples counselor, right?
Sure.
Oftentimes, though, my friends that are LMHCs or LASWs, they're not used to having tons, like a lot of people in the room, like 5 or more people in the room. And I kind of love that. Like the more people in the room, the better, because then I can really get a look at like what's going on within this dynamic and feel like I'm helping the whole family.
And that's what you mean by system, the family system, right. The dynamic between the people. You say systems to a doctor, and I was thinking the way that I was trained, because I've actually never heard it broken down like that. And so, we're trained to think in systems, but it's the endocrine system, the cardiovascular system. And I thought, that's interesting, the systems. Oh, right.
Yep.
Versus that kind of, I guess that, so I'm going to tell you what I tell patients, and I want you to tell me what an idiot I am and correct me.
Oh, gosh.
Because you are the PhD, the professor, the researcher, all the many things that you are. So one of the things, because I work with a lot of kids and young people, is that parents will say to me, well, thus and so, is it play therapy? And I'll say to people, here's what I understand about play therapy. Anything can really be play therapy. It isn't exactly like saying it's a specific this is a specific method of therapy. While using CBT type approaches or DBT type approaches or ACT type approaches, you can incorporate play. So when it's like, well, we did play therapy and it wasn't really that good for us, it's so broad that it's hard to kind of make a statement quite that exact. Is that correct?
Yes, I think there are many.
She's being nice, folks. Here it comes. Go ahead.
Well, no. Oh, yes. Is that correct about what you said? Yes. Like there are many different types of play therapy. I think the systems thinker in me always goes to it depends, right? So then it completely depends on how that person was trained in doing play therapy. Like I practice non-directive play therapy, and disclaimer too, I am not a play therapist because that is an actual designation. It's called a registered play therapist or an RPT.
Okay.
But I was trained in play therapy. Yeah, you'll see it behind like they might be like LMHC RPT, right?
Okay.
And so they went through additional training than we have from just our masters or from going to CEU trainings where you learn about how to conduct play therapy. So So the play therapy that I conduct, to go back to that, is non-directive, directive, very Adlerian style play therapy, and filial play therapy, which is, of course, my favorite because that's the type where you include the parents very directly.
I'm too stupid for this conversation.
I know.
There were two words in there. One sounded like Illyrian.
Adlerian. So Adler.
Oh, okay.
Yeah.
God, I'm an idiot. Okay.
No.
And filial meaning family.
Of the family.
Based. Right. Mm-hmm. Thank God, I got one of the two out of there. 50% is an F on any test that I... Okay. All right, go ahead before I embarrass myself further. Go.
Well, and the thing with play therapy too is that it just completely depends on what that child needs, what they're coming in for. Is it, of course, I'm always kind of I lean towards let's get the family involved as much as possible in that play therapy dynamic. There is literally models set up for family play therapy. But sometimes that child also needs a space, maybe they've been through a traumatic event and they need a space where they don't feel like they can talk with their family just yet about it. And they need to have a safe place where they know that they can share anything with me and it stays there. And so I think sometimes people who don't quite understand play therapy, like parents or family members who they don't have that strong background in it, can have a hard time. Like they'll think like, what's really getting done? Like you're just playing, right? Like how are you really helping my kid? You just played for an hour. Mm-hmm. But the basis behind play therapy is that the play is the language, right? The toys are the words, right? And that the idea that children don't talk about their problems. Like they can't sit down and have a 40-minute conversation with you about, why dad packed up and left last night and how that made him feel. They're not going to do that, but they're going to play that out. And the really kind of beautiful thing about it too is it's kind of like I would never have a client in and tell them like, okay, today you have to talk about this. Well, why would I have a kid in and say, okay, today you have to play this or you have to talk about this? Like, how safe is that kid going to feel, right? And so non-directive play therapy, which is the approach that I often do more so than directive, is that idea of you are free in this room to play with anything that you want in any way that you want. There are no rules unless I need to make one, and this is a completely safe space. Yeah. And I'm not even going to tell your parent what you played with, right? Like, this is just a time for me and you, and just for you, right? And how much you include me, totally up to you, right? I mean, very much like you are free to be you, unconditional positive regard. How often do kids get that type of control in their life, right? To just allow to be the decision maker for that entire hour.
Yeah. So one of the things that I guess I assume that people know is that, but I shouldn't, is that when you see someone like me, we have sort of doctor-patient confidentiality. See somebody like you, they have doctor, because you're a PhD, right. Doctor-patient confidentiality. When it comes to minors, on the therapy side, what responsibility do you have in terms of keeping confidentiality versus sharing with the parents because they are under 18? And where I have no idea the answer to this. Like, I know where it is for us, but where is that line of legality and trust and rapport? What say you?
So essentially, I mean, minors are given the same confidentiality rights as anyone else, right? Like, I need to protect their confidentiality. Like, the toughest thing I will tell you, but it's also kind of, I love it and it's hilarious. So, you always run into your clients at like Hy-Vee, Target, like stuff like that. And the funniest thing though is when, I always say in the first session with someone that I will, if we ever meet out in public, I will never introduce myself, or I will never come up and talk with you unless you come up and talk with me first. And I do that to protect your confidentiality so you don't have to explain to someone who I am. But a 5-year-old doesn't really understand that, right? So when you have a 5-year-old running across Target, running away from their parent because they see Dr. Heather and they're like, Dr. Heather, and they run up and grab your legs and you're like, oh, sorry to the parent.
Yeah, kind of nod at them.
Yeah, like, oh, hi. And so that's just a funny side note. But the same applies with kids, right? And so you try to explain that to them as best as possible, and you try to break down confidentiality to their level, depending on the kid's age. But when it comes to, like, I always tell minors and anyone under 18 is what I'm talking about there, that anything that you tell me, right, unless it's you're letting me know that you want to hurt yourself, someone is hurting you, or you want to hurt someone, right, it stays between us. However, if I'm really, really, really worried about you, right, then I might need to tell your parents and I might need to talk with them. So if there's like oftentimes, you'll have teenagers that are engaging in self-harming behaviors, like non-suicidal self-harm. And since it's non-suicidal, you don't really need to break that confidentiality, right? But if they are self-harming, like cutting or burning or bruising themselves, like hitting themselves, things like that, to a degree that I'm really worried about not only their mental health, like maybe they need to be hospitalized at this point, right? Because it's getting so severe. I'm worried that even though they're not suicidal, I'm worried it might cross over to that, right? Or they might accidentally hurt themselves more than they meant to. Or I'm worried about infection or things like that, then I always let them know if I'm really, truly worried about you, I can tell your parents and I will tell your parents because I care for you and I want you to be safe, but I'll never blindside them. I will always have that conversation with them first. I would never go behind their back and talk to their parents without their knowledge.
I think that's so important to establish that rapport, and it's difficult though, right? Because then
they might hide things.
Right. I mean, we obviously can't say yes, no matter what you say, it's 100%.
Right.
But at the same time, then do they withhold, or
right.
how much trust is really there? And like I said, you guys get so much more time. That there's a better chance, but also then there's more risk to them in some ways. I think that's a great way. I think it's a great way to handle it. I have about the same thing that I say, which is, unless you tell me you're going to hurt yourself or somebody else, I have no legal obligation to tell your parents. And I always throw in there, and I've actually gotten feedback, people like this. I say to the kids, remember that I work for you. In this room, I work for you, and I work for your mom, for your dad, for the school. I work for you. So my job is to care about you and advocate for you. So I will listen to what you say. So if mom is saying, well, I think the medicine is garbage, and you're saying, yeah, I don't know, I really think it's what I'm going to, especially as you get closer and closer to 18, right. I'm going to allow you more and more autonomy because I do you a disservice. The minute you turn 18, you now get 100% decision of, am I going to take this medicine or am I not?
Right.
What's your view on psychiatric medication in general?
So there's very much a divide, I think, within the marriage and family therapy world about this. Some people feeling like, no, we need to try everything else possible first. And I'm pro medication simply because I've just, not only in my personal life, but in my clients' life, I've seen it be so beneficial. I've seen it literally, I feel like, be life-saving. I've had clients tell me they felt like it was life-saving. And all the research shows that a combination of medication management and talk therapy yields you the best results. And now, am I all about, like, let's try, like, least intrusive measures for, of course, right?
Drugs for everybody. No.
Right, exactly. Like, or highest dosage, or, I don't, like, of course not, right? Like, if ever we can, less is more, right? In my opinion, with anything, right? But especially with body dysmorphic disorder, oftentimes it's, people will be really reluctant to start medication, and often it's the stigma, right? Like, what does that say about me if I take an SSRI or an antidepressant? What is that? What if my partner would find out? Or what if, they have all these bad feelings associated with that because of whatever messages they've gotten, whereas I view medication as no different than, your prescribed glasses that you wear, right? I mean, I always tell people that, like, if there was something wrong with your eyes, right, or your child's eyes, like if the stigma of it is really keeping them from taking that step, like, would you ever tell yourself or tell someone else or your child, like, that's just how you have to look at the world now? Like, suck it up. Like, just keep, I know it's blurry. I know it sucks. I know you can't really see anything, but, glasses, I mean, people are really going to make fun of you if you have glasses. You know what I mean? Like, no, you'd say, let's go to the optometrist. Let's get this figured out. Let's get you a prescription, right? Because that's all glasses are. And let's help you to be your best self, And so medication, what's wrong with that?
I swear that I didn't set any of that up, but you and I see eye to eye on that. in the military, I tell people I was basically a therapist. That's what I did the whole time. I am big time pro therapy. I think that the proper dose is the least amount that you can use. A lot of times people will come to me for an initial evaluation, and I always talk about therapy, and they'll decide, I want to start with therapy and not use medicines, and I always say that's great. In fact, I always start out by just kind of lighten it up, but I believe this. I always say, I'm not a drug dealer. I don't make any more money if I give you more or less. I just want what's best for you or for your kid. And then I often use sort of medical examples like that. A previous guest talked about his own struggle with depression and suicidality, and he basically said he thinks that it's all garbage and you have to just eat well and exercise and suck it up and pull yourself out of it. And he was a very inspiring guy. I don't want to talk down to him. It was a great episode. I really enjoyed talking to him. But if you had someone who was saying something like that, what would be your response?
I'd say if that works for you, awesome, right? If that works for you, fantastic. That's not going to work for everybody, right? And, I know like my own struggle with body dysmorphic disorder, sometimes and we can get into that if we want, but sometimes you see yourself in very distorted, kind of abstract ways is kind of the best way that I can really put it. Like if your face became an abstract painting as a reflection, when you're looking at yourself in the mirror. And I don't think any amount of exercise or eating well or sleep, granted, that's going to help. Absolutely, right? That's going to help my brain do what it's supposed to do. But prior to taking an SSRI, I didn't find that solution for me. Sure. And I know that's been the case for hundreds of clientele.
So let's just go ahead and get into this now. That was a beautiful intro, and rather than me try to redirect the conversation, which would make no sense, let me play the listener for a second and say this. Okay, so body dysmorphic disorder, I think I heard of that once. Isn't that when people are really skinny and they look in the mirror and they think they look fat no matter what they do? What is there really to that? So tell us as much as you wish to share about your own story. Why don't you define it for us a little bit, and then I can't wait to hear about it from your perspective.
So you're right. That's one of the ways that it might manifest in an individual. But so if I just put my teaching hat on for a moment.
Sure.
So body dysmorphic disorder is a preoccupation with either a slight or an imagined or perceived imperfection in one's appearance. And it is very, very similar to OCD, right?
Okay.
So except the intrusive thoughts are surrounded around one's appearance only. And the compulsive behaviors are all about trying to either change or manipulate or hide those things that we perceive as being deformed. Oftentimes individuals with body dysmorphia, they'll describe themselves as hideous, monstrous. So it's not just someone being like, oh, I don't look good. Oh, I don't like how my nose looks, or right? Because everybody's like that. Because oftentimes when I talk with people about my passion for working with individuals with BDD, that's the short term for it. They'll say, and I know they don't come from like a bad place or anything, but they'll say things like, well, doesn't everybody not like their appearance once in a while? And it's like, well, yeah, like everybody doesn't like their appearance once in a while. This is, imagine looking in the mirror and feeling like you are so hideous and deformed that you can't leave the house because you're afraid you're going to scare people. Because you look like that deformed figure that you saw in the scary movie, right? And then the repetitive compulsive behaviors that they could take the form of mirror checking, right? So you're constantly checking your appearance multiple times a day, sometimes for hours a day, or you're checking for imperfections on your body, right? So there could be checking like physically checking with your hands right in front of the mirror or not. There could be complete mirror avoidance and it doesn't have to be just mirrors, it could be reflective surfaces, right? Where it's like, I am not going to look at myself at all because I'm so hideous, I scare myself, right? And so some people, they see something kind of very abstract sometimes and literally deformed. Other people, it's this fear of looking that way that keeps them coming back and doing the checking. Other forms of compulsive behaviors can be obsessively changing their clothes multiple times a day, oftentimes trying to hide the area of their body that they view is deformed or defective. And most of the time, although it can be about any area of your body, typically it's skin, hair, and nose in that order.
Okay.
So, and oftentimes it's more directed at the person's face, that they'll see their face is very deformed and defective, and that their skin on their face, that there's something wrong with that, whether it be like a rash that isn't there, or that the rash is worse than it is, or acne or scars, or literally that their face is misshaped. It will be fear and obsession with their hair and having too much hair or too little hair. And then, of course, the nose, right? And this idea that there's something monstrously wrong with their nose. But again, it can be any form of the body. Very typical next area of their body is their stomach, right? But oftentimes, people will change their clothes multiple times a day as a way to try to camouflage those certain areas. So they might try to camouflage their face with like changing their hair or wearing hats or doing excessive grooming rituals, right? Where they're putting on makeup and taking off makeup and putting on more makeup and things like that. That's just a few. There's multiple. Yeah. When it gets into, then it can get into financial pieces where people are constantly seeking plastic surgery or seeking the care of a dermatologist, because again, it's usually about the skin or one of the areas of concern, or it'll be their teeth, that they are constantly worried about how their teeth look, and so they'll be going to their dentist or what's the other? Orthodontist, trying to, constantly get procedure after procedure, when these professionals then typically are the ones who then refer them on to a therapist, because they're like, hey, your skin looks fine, your teeth look fine. And yet the person keeps coming back saying that there's these issues, reporting these issues, and they're like, I think this is something more psychiatric going on. But then they're oftentimes so fearful to tell anyone about their symptoms out of major fear that they'll be looked at as vain, that they'll be looked at as delusional. And so you can imagine, there was one study that looked at 75% of participants did not report their symptoms. So this was just a blind survey. They did not report their symptoms at all to their healthcare professional, and terrified of going to a therapist because they'll think, well, the therapist is just going to think that I'm crazy, and that I'm psychotic, when they're not, right? They might be having delusions, right? They might be seeing something in the mirror that's not there, but it's not due to psychosis per se. It's the BDD.
Right. So is it a chemical imbalance? Is it social media and Instagram filters drive an unrealistic perfection view? Is it all of that? Like, what's been your experience?
Well, yes, a chemical imbalance, I certainly believe. There's been 3 different studies with RCTs looking at using psychotropic medications for people with BDD, and all found it to be very, very beneficial. Okay. And usually, unfortunately, the higher dose tends to be more beneficial. Just, again, kind of very similar with OCD.
I was going to say, so of SSRIs, like Prozac and Zoloft and Lexapro and so forth.
Yep, exactly. And so, when you think about people who have OCD and maybe very, very severe OCD, they typically are going to need maybe a higher dosage and maybe more long-term therapy, more long-term like exposure and response prevention treatments than someone who maybe it's a little bit more borderline or the symptoms aren't as intense.
Sure.
And oftentimes people with BDD, they wait so long to seek help because they themselves don't even know what's going on, that the intrusive thoughts, they just create this solid neural network, right, where they just truly believe that this is how they look when they don't to someone else. So I don't know if I really answered your question with that, but I do think though that, BDD has been around for as long as we can imagine. It was in the DSM-3, I believe, it was called dysmorphia, right? Which is literally like the fear of being deformed. In ancient Greece, it was called dysmorphia, if I'm saying that correctly, which sounds like a naughty word, but that's not what I mean. So, where literally there's the story of this woman who she had her nurse constantly take her to the temple so she could pray to the gods so that they could fix how she looked because she looked so hideous, so deformed, right? So now do I think that social media makes it worse? Of course, right? Like anything, right? With anyone with any type of body image issues, when you're constantly seeing these ideas of perfection, of course it's going to make you question yourself and question your appearance. So yeah, I definitely don't think it helps, but I don't think it's definitely not a cause. You know, it's BDD has been around long before that.
Sure.
What else do I want to say about that? There has been an issue within, so I belong to a lot of body dysmorphia message boards and the National BDD Foundation. It's bddfoundation.org is a wonderful, wonderful resource as well if you want to learn more about BDD. But they recently, there have been reports out about individuals who Snapchat filters, right? So they will, often that can be another compulsion, is taking numerous pictures of yourself and trying to confirm or disconfirm, do I look a certain way, right? Or do I look okay? And one of the things that professionals have noticed is that people will take these pictures of themselves using filters and they'll go to dermatologists or plastic surgeons asking to have surgery to make them look like that.
Wow.
Yeah.
You know what else is crazy with those filters? So I'm on like these dating apps because I'm single and that's what you do in 2019, I guess. But some of these girls will have nothing but Snapchat filter photos on their like dating profiles. So like you're looking at them and they got dog nose and dog ears in the one, or monkey ears in the next one, or sparkles on their cheeks in the next one, and I'm like, I don't even know what you really look like. Like,
yeah.
What do you think that this is attractive to me? Like, just whatever this facade is, you know, these dog ears or whatever.
Sometimes I'm glad I'm married and have been off the market for a long time.
Right. I feel so bad for people.
Yeah. One of the things, and I've been saying this for a lot of years, and I think that all throughout my life, whenever I've said this to women when I've been single and they've been singles, I think they think I was trying to get into their pants, but I've always been serious when I've said this, is that I actually think that women look better without makeup on, because if what you love is them with their makeup on, then you're not loving them. If that's what you're wanting to sleep with, first of all, it's usually dark, but maybe I'm too much of an Iowa Protestant. But anyway, but if that's what you want, is if it's I love their heels, or I love their whatever, and I'm sure it's true. It'd be true with guys and my gay friends. Like if what you liked was how their ass looked in those jeans, it's not them, but that's a very beta male thing to say. But you know, back when I was dating, there wasn't Instagram and there wasn't as much filter stuff. So it's interesting because Cooper's 24, and so there's a lot of different pressures, I think, in his generation.
You gotta look at the tagged photos.
That's a good little clue to every hint.
So like on Instagram, you have your photos that you post, and then you have photos that people tag you in.
Right.
So the ones that you get tagged in, you got to check those to see what they look like in other people's photos before you just take it.
I'm trying to think. There was I think it was a singer recently that posted a completely unfiltered picture and was had a big thing that was like, see my cellulite, this is what I look like. You know, and there have been a lot of different videos that I've seen where they show the picture and then they sort of back off all the photoshopping and the filters and say, this is really what the person looked like ahead of time. And of course, Photoshop's been going on. I didn't even know it had been going on for as long as it had been. I heard somebody on a different podcast talk about it at one point, and I thought, you know, if you'd have asked me when it started, I would have said it was much later than apparently it was. And you hear about, you know, they were blurring out Sean Connery's tattoos way back in the Bond days and all of that. But yeah, how much of your story are you willing to share? I would love to hear it, but I don't want to make you uncomfortable.
Oh, sure. No, I'm usually an open book to people about it, so there's probably pieces of it that I wouldn't share, but
sure.
But I write about, if you read my if you, that's the sad thing. Whenever you write, like it's something you do a lot. I was going to say whenever you write a dissertation, but
every other week when you're writing a doctoral thesis and dissertation,
yeah, that type of thing. So no, my dissertation was looking at relationships and attachment and body dysmorphia. So more specifically, exploring the lived experiences of individuals with body dysmorphia and how they feel that it impacted their relationships and how relationships impacted their symptoms.
Okay.
And it was fascinating and I loved it. And except for the pressure of getting my PhD done so I could graduate on time, like that part was awful, but I love qualitative research. I think it's the therapist in me. I love talking with people, but in there I share a bit about my story. When you're a qualitative researcher, you like own your own bias and you share like, this is where I'm coming from. This is why this matters to me. So part of that, so it's out in the world. So, but I think my body dysmorphia really kind of started up as a result of a switch from, so to back up a bit, came from broken home and parents divorced when I was 3. Mom and dad both got remarried to different people when I was 8 years old. So it was like an awful year of my life. And just because of a lot of change, right? And my dad's marriage only lasted a year. During that time too, there was abuse that occurred. And I won't go into that part, but as a result of that, I think as a result of major changes going on in my life, as you know, whenever someone is like, it's systems, right? Whenever someone is going through major stress, things in the body tend to act up, right? And so first started out, symptoms started manifesting in me of, I just was physically sick, like all the time. And then OCD manifested, and I struggled with some contamination OCD for about a year. And where I was just washing my hands constantly, was constantly afraid to touch certain things. I would only touch certain things in certain ways, like turning off light switches with like my elbow or trying to open doors with like my forearms. And it was just awful. And I don't know if parents realized it or saw it or didn't. I don't, it's all of it's kind of fuzzy, but I remember there being times where my hands were just red and cracked and bleeding and just in pain and thinking like, I don't want to do this anymore. And so somehow without treatment, I worked myself out of that somehow. But by then it was probably like 11 or 12. And I know 12 and 13 was when body dysmorphia really hit hard for me.
Okay.
And I think that that's often a time for a lot of people. I feel like from my experience with people, with working with clients that, 4th grade is about when body image stuff starts up for people. It's like before that, I feel like kids don't, and this could, again, totally different for everybody, but sometimes, when kids are young, nobody really cares what anybody looks like, but then you reach a certain grade and everybody really starts to care. And that all of a sudden feels like really, really important. And so I don't know if symptoms kind of started to kind of manifest in that way too. I'm sure that didn't help, but of course, everybody doesn't struggle with BDD. But about 12 and 13 is typically when it sets on for people, and that definitely hit hard for me, where I would just spend hours a day, trying to get ready for the day, trying to feel like I looked good enough to go outside, to even have anyone see me. And then sometimes it wasn't good enough, and so I would stay inside anyway, and like wouldn't meet up with my friends, wouldn't try out for different things for school, didn't want to go to school. It sucked. It was not a fun time in my life. Somehow, again, kind of worked out of that. Somehow just, I don't know if it's just perseverance or just, I think sometimes literally getting sick of symptoms. I don't know if you've ever seen that in clients as well, or
Totally.
patients that, it's like, God damn it, I just want to be done with this. And so I just, kind of like forcing yourself to, now I know it's like forcing myself to do those ERP, exposure response prevention exercises that I try to teach people to do, right? And I was like doing it for myself without knowing it. And so slowly, it kind of went through phases. It got better with time and not with time. But one of the things that I really realized, like in my own therapy now over the years, and with working with clients too, and it's very systems theory-esque, that, symptoms really serve a purpose. They serve a function. And I'm a big believer that they serve as a distraction from emotional distress, from relational distress. Mm-hmm. And I've noticed in my own history that whenever I'm having relational distress, be it with like a partner or a friend or family member, that's when my symptoms go right through the roof. When relationships are good, I tend to feel good about how I look, right? When there's a lot of stress in the relationship, or I'm worried about things in the relationship, it's crap. And I was previously married before I have like the most amazing husband in the world now, and so I'm super happy.
Shout out to Justin.
Shout out to Justin. He's like the most amazing thing in the world. I know I'm biased, but how often do you get to hear that from people that like I truly believe that I'm like married the best man in the world, because he's just so supportive and just awesome. And he never makes my symptoms flare up.
Good.
Other things do, I think, like other stressful relationships in life can make that happen. I forget where I was going with that. I was previously married. I want to call him like Captain Douche of the SS Douche Canoe. It's like,
all right.
I pre-warn my clients and my students that I am a swearer, but yes. And
listen, this is a free forum. You can say whatever you want.
I look back now though, and God, my symptoms were horrible during that entire marriage. Like because it was unhealthy. I got married young. It was one of those things where I shouldn't have gotten married when I did, and just very unhealthy all around. And it's just a much happier place now. But it's always, you wish that at the time you could have seen like, this is why I'm feeling what I'm feeling. But I think BDD kind of served as, I didn't want to deal with what I knew was so unhealthy and I didn't want my marriage to end. I didn't want it to fail. That idea of like, well, if it fails, I've failed. And what does all that mean? And so I think that turning towards something I felt like I could possibly control, right? Like how you look, right? And trying to manipulate that and having some semblance of control over that. That was just, okay, I don't want to think about all this other bad over here in my marriage, so I'm just going to focus on this.
Mm-hmm. So I have an interest in eating disorders, and have worked with a lot of eating disorder patients, mm-hmm. and there's a lot of commonality in what you just said mm-hmm. with control. We used to say that EDO is not about food weight, size, or shape, which everybody thinks, right? Yeah. It's really about control, and you can usually find something in somebody's past where they were either out of control, whether it be abuse or, a lot of the patients I worked with were very high functioning, had big degrees, they were a hell of a lot smarter than I ever was. So, and then like you say, when stress flares up, yep. It's sort of even though it's destructive, there's a comfort in I can control this, mm-hmm. What I put in my mouth, or in the example that you used of, how I wear my hair so that these ears that are like Dumbo or whatever it would be are right. not as prominent or something like that.
Yep, exactly. Yeah.
One of the things that I've always said I'm going to write a paper about, but it's probably been done 1,000 times, is that people that have been sexually abused, as an example, will often find something empowering, like they become adult dancers, or they work in the porn industry, or they become lingerie models. They somehow find a way to take it back mm-hmm. in a way. And when I think about something like body dysmorphia, I was curious. I don't know if you've ever interacted with the bodybuilding world or the modeling world, or is there any component of that you've seen or that you would recommend, or what if a client said to you, I'm going to do this thing to take it back? Like, what would you say?
So I'm going to say what my students hate when I say it depends. I think it because I have a little bit of it. Oh, this is like embarrassing for me too, but it shouldn't be embarrassing. But it's a little bit embarrassing.
It's just you and me and Cooper and however many thousand people choose to listen to this.
Yeah, exactly.
So
right. So I did like a little short stint in pageantry circuits, and I think that that was really because I wanted to prove that I was good enough looking.
Okay.
Like if I could look like those girls, then, or if I could make the top 10, or if I could, actually win, oh my gosh, well then I must be okay looking enough, right?
The external validation, I guess, is
right. Exactly, which I think was extremely unhealthy for me. My first pageant was under the Miss USA system, and it was Miss Iowa USA, and I had lost a lot of weight for that because I felt like, well, I have to lose a lot of weight, right, to do this. And I'd actually had people there tell me that I needed to gain weight, like if I wanted to be viewed as, potential, and I think that pageants could be wonderful too, in that they can lift up someone's confidence. Like you have to have a lot of freaking bravery to walk out on that stage in stiletto, like, what's it called? Lucite heels, right? Which, but they're like crazy tall, and yeah, but you have to have a lot of bravery to do that in a swimsuit in front of hundreds of people. I don't know how I did it looking back, because now I think I'd be like, I don't know. So if anything, I mean, I think like it, because I always still get nervous before a class, and that's like 20 to 25 students, but I still get like, I always joke with my students, like, don't get too close to me. I'm probably stinky. Because I just get a little nervous. Like it's public speaking essentially, right?
It means you care. It means you care. And I'm just a quick thing. I tell this people all the time. I was a professional actor, and I haven't, because of my daughter, I haven't done a lot of theater in the last 3 or 4 years. But people would ask me, do you still get nervous when you audition? And then half the time they'd say, well, surely you don't get nervous anymore. You were in New York, you did all this high level theater. And the answer is no, every single time. And if I don't, I know I don't want it. And then, now that it's not my living anymore, I don't audition.
Yeah.
So before I would talk for your class, even before shows like this, that's what I think that means. I think you care about your classes and your students and so forth. Please continue.
Yeah. So I would say for me, it was unhealthy because my reason for joining pageants was unhealthy. And I think there was a part of me that knew that at the time even, but that desire to, I don't know, to have that answer or to have that validation was too strong. And I won't lie to you, I've always been a girly girl at heart. Like growing up, I've always been a girly girl. And so I always I like that idea of like doing hair and makeup and dressing pretty. And, so there's that too.
How did you do in the pageants?
So my second year at Miss Iowa USA, I did get in top 10, which again, I think was not at the time, it was like this, like, oh my gosh, I've proven it to myself, right? But then when third year, you don't. Well, what does that mean? Okay. Are the girls, because the other part of it that can be so unhealthy is, often with BDD, you're comparing yourself constantly, right, to other people. And that's another compulsion within it, right, is you're constantly comparing your looks, your body, everything to someone else, and which is not fair to do to yourself. So then there's that, like, I didn't make it this time. What's wrong with me this year? Or these other people that are in it now, they must be better, or what, when it's totally subjective, and it's, yeah. So I would say, what is the person's reasoning behind it? Okay. And maybe really exploring with them, how do they think that, whether it be bodybuilding or, so there's a subset actually of body dysmorphia called muscle dysphoria.
Okay.
or muscle dysmorphia, and it's primarily just seen in men, but of course I'm sure there's going to be women out there who struggle with it too. And but it's the idea that the individual feels like they are too small, too slight, not muscular enough. And oftentimes these men, sometimes they do get into bodybuilding. They could be the guy who goes to the gym multiple times a day and will be so distraught if he misses his workout, will be so distraught if he ate something that he shouldn't, and they just bulk up and bulk up and bulk up and get bigger and bigger, but it's never enough. You know, they're never big enough. And of course there's always the fear of steroid abuse and things like that. But I could see that being like, if that were something my client was struggling with, that entering that might not be healthy at all.
So, I mean, it depends is a fine answer. And I always tell people, I'm a scientist. I have a hard time saying no when they're like, is it possible that it caused this really weird side effect? And I have to go, I can't say no.
Right.
But it's really, really, really unlikely.
Right.
One of the people that I'm hoping to get on, he's already said yes, is a local bodybuilding promoter. And one of the things we're going to talk about are the different categories. So a couple years ago, I got involved in the bodybuilding community and I won a show. And it's a whole other story. I don't want to talk about that. But
that was awesome.
No, it was cool. No, it was great. It was very transformational. But I didn't know anything about the bodybuilding world. So what I'm about to say is not an official study. It's just my observation. But there are many categories. There's the drug-free organizations, and then there are the ones that they're not pro-drug per se, but you're allowed to use whatever you want. That's a whole other conversation about what's good and what's not. We'll try to talk to Al about that. But then there are these different categories. And what I think is interesting, just from having talked to, between the many bodybuilding shows, the one I was in, the ones where I've spoken or gone to as a spectator, I've probably talked to 100 people. And what I think is interesting is that in the different categories, so there's bodybuilding, which is what everybody kind of thinks of. And then a lot of them have what's called classic bodybuilding or classic physique. Then there's physique, and then for women there's bikini, and then there's also, I'm going to forget one. Oh, I'm totally going to forget it now. Some of them have the athletic, but there's another one besides physique and athletic, besides physique and bikini for women. Anyway, people that lose at bodybuilding tend to go, well, better luck next time. I'm going to bulk up because, I'm just going to do better, because nobody expects you to look like that in normal society. What's really interesting is that in men's physique, they wear board shorts. They look like, the goal is to look more like an underwear model or something like that. So you're covered from your waist to your knee. So six-pack abs, biceps and back. And then in women in bikini, if a woman is too muscular, has too defined of a six-pack, she's going to lose, because that's not what that category is for. That's what the other one that I'm blanking on completely, sorry everybody, is more about. But what I think is interesting, having talked to people, is that if I lose a bodybuilding show, well, that's not what society deems as beautiful. But if I lose a physique or I lose a bikini, in a way, you're almost saying to them, well, you're not sexy, or you're not traditionally beautiful. And so there's more of a
wellness?
Figure. That's the one, figure. Yeah. Okay. So in my experience, figure, they're more muscular, they have more of a defined physique to them. In bikini, so there's a really great pro that I met when I was in Texas, who's now an IFBB pro in bikini. And so, how do I say this? The poses are sexier, and all the women's categories have to do this pose from the back that clearly is designed to look at their butts. Let's not kid ourselves here. But in the bodybuilding, it's my wife and I got into this discussion, and I still stand by what I'm going to say. She made a crack about looking at their butts. In bodybuilding, you're looking at their glutes, not their butts. And I know it sounds like the same thing, but what you're looking for is muscle definition, striation, and so forth. In a physique, in a bikini, in a figure, when you're looking at their butts, for the women especially, you're looking for curvature and so forth. It's very much a how sexy am I. So I would proffer a guess. This is my not scientific observation that I'd love to know more about. That would be harder to lose. It'd be harder on your psyche because in a way it's like you're not sexy in a way that when you're a bodybuilder it's like, well, I mean, you were a super muscular kind of freak looking anyway, so I don't know, maybe that's not true, but if you ever run into clients like that, you can let me know.
Well, I could see that because again, like you said, one is more like how society, like these images we get all the time of what is beautiful, right? Whereas you don't see in the Abercrombie ad the guy who's like, you know, huge muscle builder, you know what I mean? Yeah. So I could see that. Yeah.
Well, and it's interesting too to think about societal standards of beauty if you look at art throughout the ages. So the term that usually gets used is Rubenesque, you know, but kind of the voluptuous woman was seen as being much more sexy. The idea of
she was fertile.
Right. Well, I mean, so there wasn't as much food, right? And so if you were a little rounder, men or women, you had the ability to have excess. One of the things, if you ever read Laura Ingalls Wilder, is, you know, so women wore bonnets and long sleeves because if you were tan, that meant you were out working. And so, but now, what do we think? Skinny people that are tan, it's so different. I wish I had looked up this study, but I heard a guy on a podcast talk about, they did a study with blind men, where they had them feel mannequins. And those men picked the more voluptuous as being sexier, which I thought was interesting. And he's an evolutionary psychologist. Shout out to Gad Saad, who I love his stuff, and if anyone ever knows him, I would love to talk with him. He's a professor. He's from Lebanon, but he lives in Canada, and so he was talking about sort of these evolutionary standards of we're drawn to things for reasons of procreation and so forth. Because let's be honest, a skinny model probably hasn't had her period in a while. That person's not going to be able to breed in the same kind of way. If we're just being completely biological about it. And so I think it's interesting how standards have changed over time. What say you?
I agree.
Excellent.
I feel like and I think the same goes too for men, you know, because one of the things too, I think that is so important to point out, like with body dysmorphia, it's about equally common in men and women.
Okay.
It tends to be reported a little bit more in women. So it's found to be more prevalent in women, however, right? That I think it's like 2.7% in women, 2.4% in men or something. And it's overall like 2.5% of the American population, which is a lot of people. That's like 7.5 million people, right? But then again, we know women tend to use mental health services more, so it could just be reported more. But even individuals that I've worked with, you know, or not, like if I just step outside of individuals with BDD, if I just focus, like men that I've worked with, men have body image issues just as much as women, you know, and I think that that's something that women or even female therapists need to make sure that they stay aware of too, that because so often our society is like, well, guys don't think about how they look or they don't worry about that. Yes, they do. They do. They worry about it just as much as women do. And so just to not assume, I think if you're a therapist or a provider, to not assume that guys don't struggle with that stuff too. You know, they aren't as socialized that it's okay to talk about it.
Right. Same thing with eating disorders, I would say. Yeah. There's so much I want to ask you. I keep forgetting and then remembering. I should start writing things down, but I don't want to be rude because I like giving people eye contact. You mentioned an age range where you said it starts to show up. Is it later in boys, or is it the same age range?
Typically about the same.
Okay. Yeah. I would have guessed, so I would have failed in your class, Professor Heather, that I would have guessed it would have been later in men, just thinking about maturation rates and in terms of, because you were mentioning 4th grade, and I would have said, granted, it was more than 20 years ago that I was in high school, but I would have said that the girls started talking about boys and dating 5th, 6th grade, and then the boys, it was, in terms of being serious, like we were jacking around and wanting to look at our friends' brothers' Playboys, but we were all like, I don't really get this. It was later. It was more like 7th, 8th grade, maybe even 9th grade. I will say that, so you mentioned the pageants. Things like toddlers and tiaras scare the shit out of me, especially as the father of a daughter. And then I think about the hypersexualization that I think the internet's fantastic. I think it's brought us the information of the world to our fingertips.
Right.
For people like that have BDD, we talked about, social media, but they also can Google it, find your clinic, find 1,000 message boards that didn't exist when I was a kid. But then it's like, as we're sort of thinking about how does it manifest, there's so much pressure and people are posting photos and videos. And I mean, the whole age thing, I think is interesting because even with a little kid, my daughter will be 4 in October. When we go to buy her swimsuits, they've got these little bikinis, and it's like, you're kidding me, for a 4-year-old. But I don't know that they had that as much when I was a kid. So I don't know. I feel like an old man being like, it's so sexualized now compared to what it was. Halloween costumes. She found a Barbie recently. She's going to be a witch for Halloween. She's so excited.
Aww.
She found a Barbie in the grocery store, and I bought it for her because I'm a sucker. But like, it's because in her mind, it's Barbie dressed as a witch. It's Barbie dressed as a slut witch. I mean, it's not even funny. Like, it's knee-high leather boots and a short skirt and all this crap. And it's sort of like, oh my God, I don't know. Like, am I off base? Do you think I'm kind of in there? Like, what do you think?
My first reaction is like, let's not slut shame Barbie, right? Right. But I hear you. It's kind of like what the college girl would wear on Halloween, right? I don't know. I have a little bit of a different. There's a part of me that thinks, is like a little girl in a bikini only sexual because, I mean, we sexualize it. She doesn't sexualize it. We do, right?
Sure.
And I think that that's a part of our culture. Like, we've been taught that a bikini equals sexy. A bikini should look sexy. And so then when you see that same thing on a little girl, because I don't know, I've never, I'm not saying, because I know people don't do that, right? But like, I don't look at a little girl in a bikini, and I usually have that like, oh, it's cute, look at the little ruffles,
sure,
right? Like, I've never thought, oh, that's sexy. But I could see though where the public is like, well, that could be sexualizing her. And
are you familiar with the concept of pedophile signaling?
I've heard of it. You need to remind me.
So YouTube, not that long ago.
Oh, is this the thing where they find pictures?
Yeah, changed the ability to comment on certain videos because, yes, you don't look at little boys or girls in outfits as being sexual, and so do most people.
Most people, right.
But I mean, toddlers and tiaras is just one example, but there's a lot, again, with the good of something like the internet comes the ends, the extremes, okay? I don't want to, like you said, I don't want to shame. I actually want to get back to the shaming thing in a minute, but it's, so you will probably have children at some point. Nothing has changed my life in every topic more than having a kid. And having a girl as a man is very interesting for what I'm then going to get back into, because I'd like to hear your opinion as a woman, as a therapist, as a so forth, because there are double standards, right? So a man that has a lot of sex is a stud, a woman that has a lot of sex is a slut, and I shouldn't have, I guess maybe I shouldn't have thrown that word out there. But there's that, and then the thing about the dad bod has kind of come around, I think, because it's famous people, and they're like, we don't want to say that thus and so looks bad. The mom bod is not a thing I've ever heard about. But, and this is where I wanted to get to, there's a big push to not fat shame, which I think fat shaming is terrible, but it goes a step further. So I think it was Chelsea Handler did a whole thing about it. There was a very overweight woman on the cover of something like Vogue, and the idea was not just you're good as who you are, you're beautiful the way you are, but it's healthy to be overweight. and that as a medical doctor concerns me for men and women, because I definitely don't think we should fat shame. I've struggled with my weight my whole life, never to the level of what I would say was BDD, but I like to wear baggy clothes because I've always been heavy. I was told in high school nobody would ever love me because I was fat, by a girl that I worked up my nerve to ask out for a long time. That was a big slap in the face. It still is in my head, even though, I'm married and I've been, like you, I was married once before and I've had girlfriends. But, there's still that double standard there that I think is interesting. But then it's, medically speaking, it's false to say it's healthy. I like the idea mentally of saying love yourself at whatever size you are, but to say, oh, it's fine.
Right.
I don't know. What say you?
Well, I would agree with that because I want people to be around and live their best life, right? I mean, and this would be more up your alley, right? But as far as any time that there's higher weight issues going on, many kinds of health issues come up from that, right? So I think the biggest thing is, because all bodies are all different shapes and sizes, and so I think it's making sure, I don't know, I guess my plug would be making sure you're going to your annual checkups and making sure you're getting your blood tests run, and like, are you healthy, to be around the longest you can, right, for those people in your life. I don't know, because again, there's that person that in me that's like 100% agrees with you, but also I want people to find love for their body and compassion for their body, no matter how it looks. And so let's make sure, like I always tell my clients, like, I don't want you to work out because you want to lose weight. I want you to work out because you want to be here longer. I want you to work out for your heart health, for your head health, right? Like, I want you to work out because it starts to feel so good that you crave it, right? Not because, you want to meet a certain goal. Rather, this is just a part of your life to make sure you go to the, get a workout in 30 minutes at least 3 times a week, that type of thing.
This is a beautiful transition into gender dysphoria, I think. But just before we get into that, I want to end on a message of hope with the BDD stuff. So tell us about recovery. And let's end on a positive note. Positive things you've seen. How many people are able to recover? Let's end with good things.
Yes, yeah. So the great news is for people with body dysmorphia, and I also, a part of Resolute Therapy is I have carved out the Body Dysmorphia Clinic of Iowa, and I just love working with that population. So feel free to check out that website as well.
Absolutely. And just for everybody too, we usually ask people to give their pitches at the end, which we'll ask as well of Heather. But down, for those of you watching on YouTube, down below we will put the website so you can see that. So if any of you are struggling or just are more interested in Heather's practice or any of that, we will put those down in the description box.
Great.
Go ahead.
Great. Thank you. But there is hope, right? I've worked with so many individuals that, I think the hardest part, just like with OCD, right, is exposing yourself to those very things that you don't want to expose yourself to. It's going out of the house without makeup on. It's going and, it's making BDD wait, kind of like with making OCD right? Like when you have that urge to wash your hands if you have contamination OCD, like that urge that you have to check in the mirror with BDD, make it wait. Set the timer for 15 minutes and then do your deep breathing, do your grounding exercises. And then once that timer goes off, then ask yourself, okay, do I really need to go check? Or do I know this is just my BDD and I'm okay? Like, I know that checking is only going to reinforce the symptoms, right? So I think the biggest thing for people is recognizing that this is a disorder that is treatable, that it will get better. Not that it can, it will get better when you do the work, right? And the work is those exposure and response prevention exercises. There's amazing workbooks out there. There's The Broken Mirror by Catherine Phillips, who is a leading expert in BDD in the world, right? Is an amazing book to learn more about it too. And but I work from a solution-focused base, but I infuse CBT, which is cognitive behavioral therapy, approaches into it as well because CBT is found to be effective. So, But I would also encourage people that if you are working with a therapist already, a lot of therapists, a lot of mental health professionals don't know a lot about body dysmorphia because it's just not really talked about in schools. I went to this wonderful training once it was looking at OCD, right? And it was OCD in the family system and how you could work with the whole family to help treat that individual. And knowing that BDD is just the other side of the coin, right? Same coin, just opposite sides for OCD and BDD. And I got so excited thinking like, oh, I bet they're going to cover stuff about BDD. How could they not, right? They literally brushed over it. Like, I never forget the speaker saying, oh, and then there's body dysmorphia, which is like really difficult to treat, and then went on.
Wow.
And just covered multitudes of forms of OCD, not that. And so I think that the knowledge about it isn't out there. And so if, to advocate for yourself, because it is your therapist's job. It is not your job to teach your therapist about these maladies, right? It is the therapist's job to learn about it and to better support you. And so say like, hey, there's this book that I would love for you to look into, or hey, there's this bddfoundation.org website. Please look at this information. I think this is what I'm struggling with. So
well, and I certainly have learned a lot today. And on that note, I will say that I learn from patients all the time. Patients really are their own best advocates. Yeah. We get really busy, which is not a great excuse, but there's only so much you can know about different things. And it's not uncommon for someone to say to me, hey, what do you know about this? And have you thought about this? And, here's a thing you can read. And so I would echo that. Definitely, if you have a question, bring it up. Yeah, absolutely. We got started a little late. I want to be respectful of everyone's time. How far are we in right now?
We're at 1:22 coming up.
Okay, so about 2 hours we turn to pumpkins for right now. But I want to make sure that we move on and talk about gender dysphoria and the transgender sort of movement. It's big in the country right now. So tell us about kind of your interactions with it, how you kind of came to study it and all that.
Yeah. So it is a population that's just near and dear to my heart. Part of it is kind of selfish as a therapist, I think, simply because, I don't know, it's weird to call it selfish, but it is so amazing to get to see these individuals go through their transitioning process in whatever that way that means for them, and to see all these other symptoms of depression, suicidality, substance use, social anxiety, like all of these other symptoms just fade away as they become true to who they are. And so I think that's where it's like, oh, I just love that part. Right? It makes me love what I do to get to see them be so happy and better functioning, and because they're just being who they are. But I became introduced to working in the LGBTQIA plus population when I was at University of Iowa completing my doctorate, and we had the LGBTQ counseling clinic there that works directly with the LGBTQ clinic at Iowa River Landing for University of Iowa, and amazing clinics. They do amazing work there. And at the counseling clinic, we performed, for one, it was all free counseling, right, for anyone in the community, but especially for individuals who were any part of the LGBT population. But we also provided free it was all free counseling, but we also did free assessments for individuals who wanted to begin HRT, hormone replacement therapy, or gender affirming surgeries. And getting to work with that population, I think many of my colleagues as well, you fall in love with wanting to help these people get on their path to being their best self. But for me specifically, because a lot of my clients will ask me, like, why you? Do you have a family member? Or do you have, right? And like, why are you interested in this? And I think for me, it's my own struggle with body dysmorphia. Mm-hmm. So again, even though they're two completely different concerns, I know what it feels like to look in the mirror and see something that you don't like. Even though mine has nothing to do with my gender, like I feel great in my own gender, but the way that it's always been described for me from clients is like, imagine if you looked in the mirror and what you saw looking back at you, the man that you are, right? The very masculine man that you are, you're just crushed because it's not what you know you're supposed to see. You are supposed to see this female looking back at you. And or, sometimes it's not, people with gender dysphoria, it can be not that they feel like the other gender, but that there's somewhere in between, right? And so regardless of how their symptoms kind of manifest, it's helping them to figure out what does transitioning look like for them. Is transitioning what they want or need? Like maybe they're more androgynous, right? Maybe they prefer more they, them, their pronouns, and helping them to be able to be that advocate for themselves, to assert that to their family and friends. And what does that look like, right? And so exploring that path with them of what does helping them to be their best self. So that part of me that loves ambiguity kind of loves that too. Like you really get to work collaboratively with that person of what does this preferred future look like, rather than there being this direct map for every person, right?
Sure. So one of the things that I think people really struggle with is, first of all, you compared it to body dysmorphia, and we've already sort of a little bit in flavor. So what you said was it's near and dear to my heart because I had these issues and so forth.
Right.
People would say, and this is again me playing devil's advocate, Dr. Peter Daniolos, who was one of my professors at the U, he's a child psychiatrist. He does a lot of work with younger people, and I would love to get him on the show. He's very busy, and that's what he said when I asked him at one point, but at some point in the future. But I think a lot of people are skeptical. Sure. And they would say, well, we've sort of agreed in this conversation that BDD is psychopathology in a way. I mean, you're imagining your nose, your skin, your face. So then, especially with young people, isn't this just another form of psychopathology or delusion or sort of questioning when you're young? At what ages have you sort of started working with people? At what ages do you see it manifesting? At what ages do you think it's real versus perceived? Like, what's your take on that?
I think what I would say to my first initial reaction to, for one, I completely understand when people don't have the awareness or the background or the work with these populations that they be skeptical, right? I think any and all of us have had, where we're ignorant to certain things and then we're skeptical. But I would say they don't have the understanding yet, right? They have not. And I think so much too, the personal is political, right? Like once you know someone, once you work with this population, it's like, oh my gosh, okay, I can get it now, right? So I think oftentimes there's just not experience with it. Especially like if it be clinicians or physicians. So what we often see though with it, so I'll jump around a little bit. Yeah. What we often see is that, symptoms can manifest in childhood as young as 2 and 3 years old, right? Oh yeah. I've worked with, I don't want to name specific ages, but I've worked with children, younger than 10 years old, younger than like beginning adolescence, right? And I've worked with individuals from 3 on up to 70 years old that are struggling with gender dysphoria. And one of the things that the public should be aware of, or that, people who are struggling with this should be aware of, like in children, what can happen is, and this is found in WPATH standards of care as well, is that oftentimes before adolescence, if there's gender dysphoria, more times than not, those children begin to feel more and more comfortable in their own skin.
Okay.
And the dysphoria tends to go away in adolescence. If it does not, though, right, then if they're persistent, there's 3 terms: persistent, consistent, and insistent, that they are of the wrong gender, right, that they are the other gender, or that they are simply gender nonconforming, right?
Sure.
And so if we see, because it's like oftentimes people use that word phase, right? This is just a phase. Mm-hmm. When does it stop being a phase? And I think that's when it's, again, insistent, persistent, consistent, right? And because we know, I mean, if that child is demanding, right? And if these demands are not validated and listened to and given space to be able to explore, it can cause a lot of issues for that kiddo. You know, if you're told you're wrong about what you think and you feel and about who you think you are, what does that do to anybody? You know, but especially a little kid like that. So I talk with parents about, we call it the watchful waiting phase. So when they're young, right, you know, a great thing to do. So there's Dr. Larsenodi at University of Iowa, who's a pediatric endocrinologist, amazing person, and also works at the LGBTQ clinic at our River Landing, and Dr. Mboric and Dr. Nicely. Wonderful people.
Those are the two I know. I wasn't familiar with the endocrinologist, but those two I knew.
Yeah. And so one of the things that I talk with parents about is maybe we need to go and talk with an endocrinologist like Dr. Larsenodi, and there's hormone blockers, right? So a great thing that you can do for children who are struggling with gender dysphoria is start hormone blockers, which is completely reversible, right? It's essentially a way to just put a pause on their puberty, right? And if we start that young enough, and if the child does indeed continue into adolescence, saying, you know, I want to be a boy, or I am a boy, I am a girl, right? This is what's right for me, and they're needing to transition, not wanting, right? They're needing to transition. Because that's what I see, right? And the research backs that up. Like if we don't allow people to be true to who they are, what happens to anybody, no matter what it is, right? Like people don't thrive. And these children, it's life or death, you know? So often, if they're not given the space to explore who they are, if they're not given the ability to transition, they become suicidal. The suicide rate for adolescents with gender dysphoria, it's like 50%. Yeah. Right? And if we have parental support, it goes down to 4%, right? And especially if we get them into therapy, and just as a place to explore, right? And just to see, you know, to talk about, like, how do you see yourself when you're an adult? Do you hope that you'll look more like mommy or more like daddy? And, you know, things like that, right? And just to be like, okay, all right, it's no big deal, right? And just who you are is who you are, and that's okay. But the hormone blockers, and one of the big things is, will insurance cover it, right? That's a big piece. But hopefully, if it will, that can lead to, because if the child does indeed continue having the dysphoria and desire to transition once they're into adolescence, you might be saving that child from so much distress when it comes to those secondary sex characteristics coming on in puberty. So, for example, if someone who is assigned female at birth, right, I'll say natal female, right, they start to develop gender dysphoria, and they, around 3-4 years old or even younger, they are demanding, I am a boy. When I grow up, I'll be a boy. When I grow up, I'll be a dad, right? We're seeing all these signs at very early young ages. And if into adolescence, they're still having these feelings, they're still feeling that way, well, oftentimes these kids, they know what's coming up with puberty, right? They've had those talks from their school or their parents. They've seen maybe an older sibling, or they know what mom or dad looks like, right? And so let's say for the natal female, right? That natal female is terrified of growing breasts, is terrified of getting their period. They don't want that, right? Well, what young girl does, but you know what I mean? Like I think about, you know, when I was young, okay, TMI, but when I was young, like, oh, I was like, what? This is going to happen monthly? This is the worst thing in the world. This is crap, right? Got handed a crap card. But I remember wanting to look like those older girls, you know, at the school, or, you know, wanting breasts, you know, and all of that. A natal female with gender dysphoria is terrified of that. And so if we start them on hormone blockers, then that development, again, just a pause button is put on there, and it could save them surgery later on. It could save them so much distress from having those secondary sex characteristics start on. And same for natal males, right? That they won't grow facial hair, they won't have putting the hormone blocker on could keep all those other secondary sex characteristics from beginning as well. So muscle development, things like that.
I would love to get
I could ramble on and on.
Well, no. I mean, there's so much here, and I would love to get either that endocrinologist or an endocrinologist on. I know the U is weird about having people talk to us, but because I think to a lot of people, the idea of giving kids hormones, because you hear about
not hormones, right, blockers.
Exactly, but this is the distinction I want to make sure that we're making, is crazy. The idea that you would give an 8-year-old or something, you would give him exogenous hormones just sounds nuts. The idea that you would do gender reassignment to somebody that was young is just sounds crazy, because little kids want to be animals, and little kids want to be all kinds of stuff. And so I haven't read the research, and I certainly don't claim to be an endocrinologist, which is why I'd love to hear from one, because I'm the idea of blocking it and there's no sort of negative repercussions.
Right.
Again, I don't know that. I'm just thinking about, but if you were on them for years and years and years and then you stopped, would it take? Because then if your peers had developed 3 years differently with extra testosterone or estrogen, are you really going to catch up? Like, what does that do to bone health? What does that do to reproductive capabilities? Like, I don't know the answer to that, but that's why I think it's an interesting conversation.
So far, the long-term research that exists shows that it's no sign. So it would be no different than someone who's technically a late bloomer, so to speak. Okay. So it kind of just speeds up to where it needs to be pretty quickly. But that's exactly why, I mean, we don't do any major medical intervention that is not reversible at a young age, because the dysphoria might go away. And they sometimes what happens is the dysphoria goes away and the children just grow up to be gay, right? But sometimes that doesn't. And so at that time, I think the biggest thing is we don't want to impose anything on that child, because it can do more harm than good, right? Sure. And what I love about the blockers is it's just a pause button. It's nothing else, right? It doesn't do or not do anything per se, right? And then it gives that child space to be able to really explore what they want for the future.
I like the idea of persistence, consistence, insistence, because I think one of the problems that could potentially come up, and I would imagine there's at least 1 or 2 listeners thinking this, is especially from a young age, if you express that this is something you're thinking about, there might be, especially if you live in a left-wing family that's very loving and accepting, there might be this overwhelming outpouring of support that then positively reinforces this to then, if you tried to step out of it, what would that be like? Would people then be mad? Are they going to think I'm lying to them? I would imagine that there would be people that would say, well, but then you're pigeonholing them in a way, and it being like, oh, because then do you switch back? And if so, do people take you seriously? Is that something that you've seen in the work you've done?
Well, I haven't seen that. However, I've seen more individuals who are just scared for their kid. They're just so, parents will be just terrified of, what if we make the wrong choice for our child medically? What if this means, oftentimes it's, what will society do to my kid? Is my kid going to be safe?
Sure.
Are they going to be made fun of at school? When is the right time to allow them to change their name at school or to use that bathroom? What if they go into a I mean, there's a lot of fears about bathrooms, right? Understandably, rightfully so. What if my child were to get beat up? And I think there's, what I see is more because doctors won't even do anything, physicians, I should say, won't even do anything other than the hormone blocker before the age of 15, 16, 17, right? Depending on the comfort level of that physician. Because again, we want to give them space and grace to be able to figure it out for themselves of what's going on. But I think my big thing would be, to any parent about anything, is we want to be cautious of our own bias because there could be a parent who loves soccer and is all about soccer and wants their kid to be all about soccer. And that kid might freaking hate soccer, right? if we force that kid to be in soccer and force them to do right, because it's what we do in this family, we're a soccer family, kid's gonna be miserable, right? And so it's kind of paying attention to your own bias as well about, because this could be like, oh, boys don't play with that, and girls don't play with this, and girls don't do that, girls do this, and okay, like, where's that coming from? And let's kind of give grace and space to the kiddo to figure that out for themselves. And
it also, though, could lilt into Munchausen's by proxy, because if your 6-year-old, if you decide, or they're deciding, or they're leaning towards it, they're saying, well, I'm the opposite gender, and you then tell everybody, and you then, the parent, get lots of support. I mean, there's that Munchausen's by proxy piece and we see it with kids that have all kinds of disorders, real or perceived, where the parents then become, well, my kid has Asperger's. And so, as you know, Asperger's went away several years ago, but it's like, but that was very much, a definition. People that get a false positive AIDS test or cancer, and then they don't have that, the studies have shown that they're more depressed when they find out that they don't have a life-threatening illness, because it became such a part of their identity. I like the idea of keep your mind open and explore, but I think that would be a tough line to walk, of supportive without pushing, like you say, into the we're a soccer family. So it's no, you said you're a little boy now. By God, we are left-wing, open-minded, super supportive. There is not a homophobic bone in our body. No. And so now everything is gonna be different pronoun, and then if the kid is like, well, I guess that's, I was kind of, as they get older, well, I was kind of, that was maybe a thing.
Right.
And, that would be one of the fears that I would have. And I think a lot of people, when they hear us say, because I have an almost 4-year-old, if you say, well, I heard a 3-year-old say this, therefore it's going to be that. That's, I think it gives a lot of people pause.
Well, yeah, and I can definitely understand that, right? I mean, because again, that's like imposing anything that's really important to you, but is it really important to your child? And I've never thought of it like the Munchausen's by proxy type avenue before, or heard of it in that way. But I can understand, like, there's that idea of, because parents also want to talk about it with their friends. They want to get support, if their child is going through this. But there's that part of me too that also thinks you don't want to out your kid, and that's where I think family therapy is so beneficial to, like, let's all explore together how we're feeling about this, and let's explore with the kiddo what they're wanting, what the parents are wanting. Why are we wanting that? What's kind of underlying some of those feelings, and what are some of the motivations behind why we're doing what we're doing. And so I just think if your child is struggling with gender dysphoria, or if you yourself are, having a therapist on your treatment team can be so beneficial to just explore all those pieces, because I could see that end of it. I often, what I have seen has been more of the opposite end of, no, we're just not going to talk about that, right? The more the right wing kind of maybe end of it is how we want to put it. But I think so much of that, again, it comes out of fear. Right. It comes out of, I don't get it. This means something is wrong, quote unquote, with my child. This means, this could mean, what is our community going to think about us? How are people going to judge us as parents?
Sure.
Oftentimes I see that end rather than the super left-wing hippy dippy kind of. No offense towards the hippies. No. I keep feeling I need to preface.
we love hippies here. So one of the things, and this is a pitch for anybody else who knows interesting people, is that I like to talk to people of all persuasions. I like to talk to intelligent people about interesting things, and I would always ask of guests that people be respectful to a degree, but I would love to hear sort of somebody else on the other side, because I think it feels to me like transgender is now what being gay was when I was in high school. So, I was involved in a lot of music and theater, and I had gay friends, and they came out and everybody said, oh no, it's a phase, you're trying to get attention, this is bullshit, and now it's much more accepted.
Yep.
Marriage is sort of not an issue for most people. It's now seen as being more extreme to not think gay marriage is okay, but now it's, but those transgender people, they're up for, they're going to get attention, they're trying to, and then of course, like anything, the extreme examples come out. You'll see a picture of a guy who it's very obviously a meme, and it's like, you think that guy should be in the women's room, and it's like, yeah, but come on, I mean, you're using an extreme example on either side. The same thing could be said.
Tactics.
No, it is, and the same thing could be said about in Thailand, the concept of the Thai boy. The man, whatever, in Thailand where gender has been more fluid for generations, and so you see a picture and it's like, what do you think that is? Well, everything looks like a woman. Well, this is, so I think it's on the cutting edge of a lot of people's minds right now. Are you familiar with Jordan Peterson? So he's,
unfortunately.
We're gonna have you back and talk about and begin by talking about this and Jordan Peterson, because I like Jordan Peterson in a lot of ways. I think he's very smart, and I think he brings up a lot of interesting things. He obviously had a lot of things to say about the language that was going to be put into law in Canada, and that's how he became very famous. I think again that the extremes sort of come out when it's like, now we're going to have 95 different pronouns, and I can switch every day if I want to, and if you don't say what I want on this day, you can be fired or arrested for a hate crime, is obviously on the extreme. But that's then where someone like Jordan Peterson comes in and says, we can't have it be to that extreme. You can be who you want and so forth, but then where's the line of extreme?
You know what I see that as?
Yeah, hit me.
I see that as absolutely no different than what gay marriage has been legalized for 8-9 years now.
Something like that.
Okay. I see that as absolutely, in my opinion, he's a charlatan. And actually, Justin would be the better person to have on to talk about him, because he's very well versed in Jordan Peterson.
You both can come back. Love to have both of you.
I see it as absolutely no different than when people were trying to make the case of, a man's going to marry a man? What's next? You going to marry a tree? Really? Like, that's how I see it. I see it as, it's something that you don't understand, you feel uncomfortable with, you're trying to draw attention to because you're trying to make money, because you're a charlatan, because you're going to speak to the audience that's in front of you. Rather, because the thing I don't like about Jordan Peterson, not to get off into that, but is he never really answers any question. Not fully. If you ask him how he feels about, there's a great YouTube video of him like discussing, someone asked how he feels about gay marriage. He doesn't give you a fucking answer, right? Because I think any answer that he gives, he's going to lose people on either side, right? And so it's, I don't know, be a person that you say what you mean what you say, stand behind your word. I just think he's out there to make money.
We found a topic where Professor Morgan-Sowada is very, very passionate. I love it.
I don't like it when people say things that are potentially hateful and mean and towards other people. I don't like it.
Sure. But this is where I think the rub of the conversation comes down to, and where I wish we had 2 more hours. So we're definitely going to have you back, and I'm not kidding. Like, I mean, I think this is very cutting edge to me, and I think conversations are really important like this, because we're never going to get to any kind of acceptance by saying, because we're very tribal, and that's in our evolution. So I'm team right. I'm always pro-life. Really, you asshole? So some 13-year-old gets raped by her uncle, and she has to carry that baby. Yep, because that's what it says. And then on the left, it's no, I'm pro-choice in every single thing ever. Really, there are 0 examples. Nope, absolutely, because I'm team left. Therefore, I have to believe in X, Y, Z. We're never, you get Antifa hitting people with bike locks, and on the other side, you get assholes marching with tiki torches. And so, but the extremes. This is my opinion, and one of the reasons why I started the show. The extremes make the news. The vast majority of us...
And money.
Right. The vast majority of us, although I wouldn't mind having a sponsor or two for this program. I'm not going to be a sellout, but I wouldn't mind having a sponsor or two.
Well, we do live in capitalist society.
The vast majority of us in the middle, though, especially in the Midwest, I think we're all very polite. don't then engage in the conversation. But we have to be, and this is why I say respectful, because I think you can easily disagree and say, because I totally hear what you just said about Jordan Peterson, and well, there's money involved, and it's no different from people going to marry a tree. But if somebody gets fired from their job, they get deplatformed, they're not allowed to even discuss sort of the anything in there in that difficult about this or any other topic. That's not, and they're going to marry a tree. That's their.
But that's also not happened. Like that's where he kind of brings up.
It hasn't happened.
Well, I'm saying Jordan Peterson had that. What did he say? Something about like, if I misgender someone, I'll be arrested or something. It's like throwing out extremes that haven't occurred. And if that, like, so then there's always that idea too of, you see this like title on news, and it's like, well, what is the story behind that? Did they really get fired because of this, or did they get fired because of all these other things that you didn't see? So I don't know. It's a skeptic in me that's always like, well, let's find out more information first rather than just going at face value. And let's not throw out like, oh, well, if we're going to allow this, are we going to allow that? Let's just hold on and actually look at things logically.
Yeah.
I just don't like these extremes. Yeah, I think that's where we agree. Like, I don't like these extremes, right? Like, whatever happened to the modernist?
Well, and again, this is where we'll pick up the next time, definitely, because there's so much there that to even throw out anything else, because I think there's so much ground that we're agreeing on. To throw out anything else would just take us a lot longer of a conversation. But this is just fantastic. Like, we didn't even get to half the stuff I wrote down, but that's just great. The one thing that I do want to ask, we're going to switch topics again, but just before we sign off and I let you pitch your whatever else you want to pitch and so forth, something that comes up a lot, that I get asked about a lot, that I'd love to hear what you, again, as a therapist and a teacher of therapists and so forth, would have to say, is patients will very frustratedly say to me, oh, I tried therapy, it didn't work. Mm-hmm. Now, I have a whole spiel that I give when they say that, but what say you when, if someone was like, but therapy just doesn't work for me?
I would say if they've tried it and it hasn't worked, you didn't find the right fit. Right? It just reminds me of, you asked me earlier about different models of therapy and whatnot, and there are so many different models of therapy, but there's also something called common factors, right? And there's 4 common factors, and these are basically common factors in therapy are indicators or predictors of what makes therapy beneficial, right? And the most important common factor is the therapeutic relationship. Like, I could be the best at any form of therapy, but if my client doesn't feel like they like me, they can trust me, and like I am there for them, right, wholly, and like I fully respect them, then it's not going to work. It's not going to matter, right? In my opinion, my robots couldn't do therapy, right? Like, there's a human connection that needs to be there, and so I would encourage them that the fit wasn't right, that it's not that therapy doesn't work, that relationship didn't work. And so sometimes you have to look around a little bit to see what, if the relationship with the next therapist is better. So, because you have to like one another and feel like they like you, right, in order for good movement to happen.
Any patients of mine that are listening are going to think I set up that answer, but I swear I didn't. Heather and I have actually never talked about this before, but I always say the same thing about rapport with the therapist. Yeah. And then what I tend to say to people is, saying that therapy didn't work is like saying that food doesn't make me full.
Yeah.
You haven't found the right kind in the right quantity, because it's like muscle memory. It's like saying, well, I tried to tie my shoe once and it didn't work out, so there's different tactics and so forth. But I'm big pro therapy. I think that the professional MMA fighter that was on before you, who was pretty anti-medicine, did say over and over again that he thought that therapy was super important, and I think it's such a big important piece of the pie. And so I think it's a much bigger piece of the pie than what I do. And that's not me being self-deprecating or putting down psychiatrists. I think that in the vast majority of diagnoses, with really only one exception, in my professional opinion. Therapy is the keystone and the cornerstone, and then medicine then supports from there. Otherwise, we're kidding ourselves. And I'll say that to patients. They'll say, yeah, I don't want to do therapy, I just want medicine. And I'll say, listen, I'm willing to work with you, but what's going to happen is you're going to get frustrated, and then you're going to be mad at me or the medicine for not doing it. And when in the pie graph that is mental health treatment, we're missing this huge component. Yeah. So I guess that's my ending way of saying, I think what you do is awesome as a therapist. I think what you do as a teacher of therapists is awesome. And this has been a fantastic conversation.
Well, thank you.
As we're wrapping, you like everyone who sends me an email that goes, I don't think I'm that interesting. Why would I be on that show? You are fantastic and totally interesting. Tell people again the website you talked about, how they can, anything else you want to pitch, whether it's Mount Mercy or any things that you do. The mic is yours before we sign off.
Yes. Well, one thing, so I'll do a few little pitches. We need more mental health professionals. I mean, our market is definitely not saturated. There are constantly times where we have to, in this field, other therapists, right, have to turn people away again and again just because they're full, right? They literally cannot take on more clients. And so we need more clinicians that are doing this work. And so the program at Mount Mercy, the Masters in Marriage and Family Therapy, we're always accepting applications, and program starts every fall, and there is of course an interview process and everything, right? But definitely check that out at mountmercy.edu/marriage and family therapy, and also check out my website, resolutetherapy.org. And one of the things that I'll end on this plug for my love of working with the trans and queer community is my co-therapist and I are starting something called Resolute Rainbows. I'm really nerding out and excited about Resolute Rainbows. So what Resolute Rainbows is it's a psychoeducation therapy group psychotherapy for children with gender dysphoria and their parents. So it's group therapy that's run concurrently with the parents in one room, the kiddos in another room, and my co-therapist is a registered play therapist. And even though we're seeing children of all ages, we start at age 4 with our group, and on up to 17, because we're really kind of targeting adolescents and children, because there's so many services out there for adults with gender dysphoria, not so much for kids, right? And so my co-therapist is going to be working with the children. I'll be working with the parents, and it's not only psychoeducation for both the parents and the kids, again, age appropriate with the kids, but it's really a way for people to meet other people in the community whose, if it's for the parents whose children are going through this struggle, for the parents who are confused about what's going on and learning more about what this would mean for their child if they do transition, and how they can be supportive, and to be able to talk about their fears, their anger, their grief, right? All those feelings in a safe place where they won't be judged, and there's just going to be compassionate care. And for the kids to get to me, because I know my co-therapist is Remy Andrews. He owns Beacon Inclusive Family Therapy Services, and so he's working with the kids, and so many of these kids that we work with, they've never met another child who's transgender. They've never met another child who is also questioning, do I want to be, am I a boy? But I want to be a girl, and trying to figure all that out, right? And so giving a space for kids to get to meet other kids who are going through the same thing, and not only learn more about their own gender identity, but to feel like I'm not alone, right? And for the parents too. So that's a group that we are currently creating wait lists for and are starting this fall.
That's so awesome. So, Heather, you've been a fantastic guest. Thank you so much for coming on. As we always end by saying, if you know any interesting people that you think would be good for the show, I would love to get their contact information from you, especially, like I said, maybe that endocrinologist. And for anybody listening, whether it be on YouTube or any of the podcast platforms, this is your show. We want to know who you want to hear from, what kinds of people. Do you know people that would be interesting? Drop us an email, drop us a comment, and we will talk to those people. So any final words?
Thank you for having me. This is awesome. It wasn't so bad.
It wasn't so bad. You were great, and Heather got in a car accident just before she came here, so she wasn't even rattled even one bit, I don't think. So
it was a slight fender bender.
So,
the lady was really apologetic.
Well, that's good. That's good. Thank you so much, and we'll see everybody the next time.
Thank you.